Teaching the interpretation of an EKG is a fairly advanced skill. If you want to have the details of that, go check out the intern guide in the intern book. What I want to do in this video is talk about the different types of arrhythmias you're going to see on the test. On the test, it's more about pattern recognition than it is in real people. They're not going to give you one that's variable, it's going to be very clear. So as you go through this video, I want you to also look in your notes where we have typical presentations of what an EKG will look like for each of the different arrhythmias. Pattern recognition is key. Let's go through arrhythmias. Arrhythmias, of course, are going to be diagnosed based on an EKG. And the first categorization you need to make are those that are fast and those that are slow. In the fast category, the next thing you need to look at is wide or narrow, QRS complex. A normal QRS complex is less than 3 little boxes, 0.12. And the narrow arrhythmias are going to be supraventricular tachycardia and AFib flutter. These are narrow complex. The fast rhythms that are wide, that is greater than 3 little boxes, or greater than 0.12 milliseconds, are going to be torsades and VTAC. All right, let's talk about first the management of each of the diseases rather than the little intricacies of each one. In supraventricular tachycardia, you're going to treat with adenosine, 6 milligrams, then 12, then 12. If they are unstable, you will shock, cardiovert. For AFib, rate control is equal to rhythm control. We'll talk about what that means in a minute. But generally, beta blockers and calcium channel blockers, if they're stable, if they're unstable, shock them. Torsades you're basically going to see only in an OB question. The answer is to give MAG and shock. For VTAC, the treatment is amiodarone if they're stable, and shock if they aren't. So I want you to see here, if they're unstable, the answer is cardioversion, shock them. If they are stable, you can use drugs, and each one has an associated medication that you should commit to memory. Again, I'm not going to draw you in these rhythms, but I want to talk through them. Give you some highlights on what you can look for in the vignette that will help you get the answer right. Supraventricular tachycardia is going to have no P waves and a heart rate greater than 150, but it is regular. A regular, narrow complex, fast, no P waves greater than 150, SVT. You compare that to AFib, where there's no P waves, but it's irregularly irregular. And the heart rate generally is not going to be greater than 150. In real life, that 150 number is useless, but on the test, look for it. Most of the time, AFib with RVR doesn't get above 150, or SVT normally does. The problem is that if you try to use this no P wave and regular thing, once you get above 160, 170, you can't tell the difference. With AFib, you're also looking for a chaotic background and in a flutter, sawtooth. For torsades, it's called torsade de pointe, turning of the points. Literally, the ectopic foci revolve around the heart, so you're going to see periods of getting bigger amplitude and smaller, bigger amplitude and smaller. It's pretty clear to see. This is changing amplitude. And the VTAC they're going to give you is going to be monomorphic. Monomorphic, wide complex, fast rhythm, VTAC. All right, one of these I want to spend a lot of time on, and that's AFib, because this is where most of your questions are going to come from. If someone comes in with atrial fibrillation, the first thing you need to do is assess their stability. Because we're going to talk a lot about stroke risk with AFib. If you have discerned them to be unstable, it doesn't matter, you're going to shock them. Cardiovert right then and there. No other consideration needs to be made. If they're unstable, they're going to die. Get them out of the rhythm. That is, of course, if they are unstable because of the rhythm. If, however, they are stable, rate control is the name of the game. And the calcium channel blockers, verapamil and diltiazem, are essentially equal to any of the beta blockers. Verapamil, diltiazem, calcium channel blockers, not amlodipine, felodipine, etc. Once you have the rate under control, that is, they have the AFib and that's it. This happens not immediately, but down the line. Then you have to ask, is it old or new? If the AFib has been present for less than 48 hours, it is considered new onset AFib, and your goal should be cardioversion. This cardioversion can occur with drugs or with shocks. The unstable variety should be a shock. If the onset of AFib is either greater than 48 hours or unknown, to consider it old. And old AFib cannot be cardioverted right off the bat. You need to do two things. The first is a 2D echocardiogram, a TTE. This is going to help you decide whether this is structural, that is, if this is a valvular disease, or non-valvular. See why this becomes important in a minute. The other thing you need to do is decide, is this person going to benefit from cardioversion? And for the next brief discussion, we're going to say yes. If the goal is cardioversion, here's what you must do. You have to anticoagulate for 3 weeks. Then do a TEE, transesophageal echocardiogram. And while you're there in the endo suite, do some form of cardioversion, either pharmacologic or electrical, and then anticoagulate still for a month. This is a simplified version of this process, and it's far more complex in real life. But what I want you to see is if you're going down the route of this person should be cardioverted and taken out of AFib, they need to be anticoagulated. You need to look to make sure there's no clot in the atrial appendage, and then do some photocardioversion and anticoagulate them afterwards. Anticoagulation here is generally performed with warfarin. If you decide that cardioversion is not the way to go, and we have lots of trials that show that rate control is equal to rhythm control, you will not have to assess the person who needs to be cardioverted versus not. That's cardiology boards. But generally, someone who is going to benefit from cardioversion is young, has no structural heart disease, and no coronary artery disease, and has very little other comorbidities. Most other patients, those who are older and have disease, should just be left in AFib, and they get rate control. Rate control is achieved without beta blockers and calcium channel blockers. The trouble is, if someone's going to be in AFib, and the reason why we did all this stuff was because a clot in the atrial appendage can flick off and cause a stroke. Cardioembolic stroke in AFib is a big topic, so let's talk about it in a little bit more detail. What it is the CHADS-2 score. It stands for CHF, hypertension, age greater than 75, diabetes, and stroke counts twice. CHADS 2, because stroke gets 2 points. Each of these are worth 1 point. And if you get enough of them, your risk is high enough for you to need anticoagulation. Simplified version of this. If your score is 0, aspirin alone. If your score is 1, then you can consider anticoagulation. If you're 2 or more, you get anticoagulation. What does anticoagulation mean? There are 2 options for anticoagulation. Warfarin with an INR of 2 to 3, or the novel oral anticoagulants, dabigatran, apixaban, or viroxaban, it doesn't matter which one it is. What you'll end up doing in life is deciding whether or not the person wants to have frequent lab draws to make sure the Coumadin or the warfarin is doing well in the right INR range, but can be reversed, or if they want the convenience of not having to have their blood tested for an INR, but having limited access to reversal if they bleed. For the test, because these novel oral anticoagulants are so expensive, you should be choosing warfarin over these new ones. And definitely in the case of valvular versus non-valvular. In valvular disease, you must choose warfarin. In non-valvular AFib, you can choose either the novel oral anticoagulants or warfarin. And the other big difference here is in valvular disease, you must bridge with low molecular weight heparin. Not because of the AFib, but because of the valvular disease. In non-valvular AFib, you do not need to bridge. Which means that if someone is going to stop anticoagulation for a procedure and they have non-valvular AFib, no molecular weight heparin. If they're going to stop their anticoagulation for a procedure and they are valvular, give them low molecular weight heparin. Lots of little details in here, but it's really important. I've also simplified this significantly. In reality, 1 or more gets a novel oral anticoagulant, and 2 or more gets Coumadin, warfarin. It depends on their gender as well. What I want you to take away is Chad's 2 score knows what it is. Know that 2 or more needs anticoagulation. You can pick warfarin or one of the new ones unless it is valvular AFib, and then you can only choose warfarin. I know, it's a lot. Let's go back through AFib one time before we move on to the slow rhythms. When someone comes in with AFib and they are an AFib with RVR in the ER, you decide unstable or stable. If unstable, you shock them. Stable, give them a calcium channel blocker or beta blocker. If you are going to say, I'm going to cardiovert this person, you first ask, how old is the AFib? If it's new, just do it. If it's old, they're going to need anticoagulation. Take a look at them, cardiovert them, then anticoagulate them, again for a month. Regardless of whether you're going to cardiovert them or not, you're going to get an echo to decide if it's valvular or non-valvular. If you are not going to cardiovert, you're going to keep them in rate control. You decide, does this person need anticoagulation anyway? 2 or more in the Chads, yes. 0, no. 1 is up in the air. Let's move on, start talking about slow rhythms. Slow rhythms, there's not really a question you have to ask. You could say wide or narrow, so let's take a look at the QRS complex. But it's not really going to change a whole lot. In the wide category, you have 3rd degree AV block, which is complete dissociation, and idioventricular rhythm. The only pacemaker for the heart is the ventricles. On the narrow side, you're going to have sinus brady, 1st degree AV block, 2nd degree AV block type 1, and 2nd degree AV block type 2. For any slow rhythm at all, if they are unstable as a product of the slow rhythm, pace them. And whether that means transcutaneous, transvenous, or they put in a permanent pacer, it doesn't matter. Every slow rhythm can be paced. If it's too slow, or if they're hemodynamically unstable. Certain rhythms can get atropine. The sinus-Brady and first-degree AV block, second-degree type 1 definitely can. There's a question about second-degree type 2, and third-degree and idioventricular rhythms, absolutely not. If you give atropine to a second-degree type 2, it can push it into a third degree. If you give atropine to a third degree, it's going to worsen the dissociation, and it's not going to do anything to the idioventricular rhythm. I'm going to walk you through these. Again, look in your text for examples. First-degree AV block has a prolonged PR interval. But no dropped beats. The PR interval is greater than 5 little boxes, 1 big box, 0.2 milliseconds. And as the block worsens, you'll see the disturbance change. Second degree type 1 is going to have a PR interval that prolongs, that is prolonging, and eventually has a dropped beat. But it will occur in a recurring pattern. The PR interval will start normal, then lengthen, and then drop. And that pattern will occur over and over again. In second degree type 2, the PR interval is prolonged, and there are random drops. And as you get into third degree AV block, there's complete AV node dissociation. What does that mean? Let's draw that. These P waves are occurring at regular frequency. But there's no QRS complex associated with them. In both third degree and idioventricular rhythm, you're going to have a wide complex rhythm. This is an idioventricular rhythm. There's no P waves, and the ventricles are going on their own, wide complex, and generally pretty slow. In third degree AV block, what you'll see is a combination of these two. You'll see that the P waves march out, the QRSs march out, but the final product is screwy because the P waves are buried inside the QRS complex. And if you find the interval, you'll realize that they march out just as they did here. This is what idioventricular rhythm looks like. This is what third degree AV block looks like. Difficult to write those out. All right, so as you begin studying arrhythmias, what I want you to realize is that a lot of your questions are going to be identify the pattern. It looks like that arrhythmia, so it is, and then the treatment. As we learned from ACLS in a nutshell, if they're unstable, shock fast ones, pace slow ones. The medications you then have to remember are going to be atropine for slow rhythms, adenosine for SVT, amiodarone for VTAC, beta blockers and calcium channel blockers for AFib flutter. Spend most of your time on this lecture learning about AFib and all the things you could potentially do and the little nuanced questions that you get asked. That's arrhythmia.